Welcome to Webisode number 9 on standing orders and scope of practice issues. I'm Eric Morse, an addiction psychiatrist with over 18 years of experience working in opioid treatment programs. A few years back, the North Carolina Board of Nursing became concerned that nurses were being forced to work outside their scope of practice at North Carolina's opioid treatment programs. They were concerned nurses were being asked to make dose decisions for patients at OTPs by following cookie-cutter standing orders that outlined dose increases that were near identical for all patients. According to the Nurses Practice Act, licensed practical nurses, or LPNs, must work under the direct supervision of registered nurses, RNs, physicians, or advanced practice providers. LPNs can participate in patient assessments, planning, and evaluation, but cannot do this independently. While LPNs are working by themselves without an RN present, it places an unfair burden that exceeded their scope of practice. An LPN must always have either an RN, physician, or an advanced practice provider immediately available for unstable patients. In the past, many OTPs wrote admission orders that looked like this: methadone, blank milligrams today, may increase by 5 to 10 milligrams every 3 days until blank milligrams. This was unacceptable by the North Carolina Board of Nursing because the nurse was expected to determine the need for a dose increase. And though RNs can collect data and make decisions, LPNs could only collect data, then present it to be interpreted by a licensed supervisor. Also, there should be some rationale for dose increases. For example, writing an order that the patient may increase for withdrawal is vague and too subjective. It is preferable to write for a short window of increases based on the COWS score. The COWS, or Clinical Opioid Withdrawal Scale, score is partly subjective and based on patient report, and partly objective, based on evaluation of observable signs. It isn't a perfect tool, but still is the most widely used instrument for opioid withdrawal. OTP providers can write for short windows of dose increases, but should clearly state the exact parameters of dose increases. Some standing orders can be detrimental if implemented for all patients, regardless of individual medical status. Obviously, starting doses for either methadone or buprenorphine will vary a great deal depending on co-occurring medical conditions, prior treatment history, other prescribed medications, and other factors. The intervals at which dose increases are done should also vary depending on the patient's characteristics. When providers write orders, we need to be clear about what we want and work with the nursing staff as a team. We do not want them to work beyond their scope of practice, which could expose them to sanctions by their licensing board. Yet we want workflow to make sense and give the best service possible to our patients. This is done when we carefully evaluate the needs of each patient and work as a team. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you so much for watching, and keep up the good work.